Hello everyone, good morning. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. It's a very interesting case. This is a 74-year-old patient from Colorado. And so she had her implants done all the way in 1982. So these are 43-year-old set of implants, the one and only that she had. So from 1982, and so silicone, the one and only set of implants. So she has had what is a complete end block, 7/17/25, initials WN. Now the first thing I want to highlight here is you look at the shape of this implant, and it was like more tube, elongated, and as you can see, 99.99% that these are ruptured. The fact that, when she and I did the phone consultation. This is this right chest mass that I removed, and we'll discuss this shortly. Look at the left side, and you see how well encapsulated this is, and much different and contracted compared to the right side. So what I'm going to do now is, this is the excess skin that I removed. She had significant ptosis, if you will. And so I removed this tissue because, as you can see, I don't want to touch this yet. These are my sterile gloves. So I want to go ahead and show, as I go in, this is abnormal tissue that I removed. And as I go in, you can see it has consistency, and we're going to dissect a little bit more. It has consistency with what is silicone granuloma within this tissue. So let's go ahead and look at this. Look at this. You see how this stickiness, the gum sign, if you will, where you have this slime type consistency. I'm actually going to cut this just to be complete. And as you will see, very hard. Remember, anything abnormal is removed. And look at the scissor. And if I go in, this is a take-home message right here. See, look at this. This is that silicone. Even though this is an end block, this is extravasated silicone. And by palpation, I removed it. I did not want to remove this precious volume, but I have to remove that silicone that has spread out. And these are irregular hard masses. And so for that reason, you can see clearly, I feel something abnormal, and I palpate this. You can see that stickiness, right? And so this is why I removed this tissue. I'm going to cut right in the middle so you can see what the consistency is. Very hard tissue, abnormal tissue. Look at this. So again, this is my new part of the glove, right? And so this is with extravasated silicone, clearly by visualization, palpation, dissection, and the history. Now what I'm going to do here is I'm going to go ahead, and this is the end block. You can see, look, some areas so thin right here, and you can see just the fact that it is elongated, just the fact it's from 1982. This is by definition a ruptured implant, all done end block, the gold standard. So I'm going to go ahead and cut this open. This is right, if just for, historical perspective, Ronald Reagan time. And you can see it's calcified and very old implant. And this is a nice lady, very well read, from the mountains. And as you will see, look at this very old implant. She lived a good part of her life with this, all contained. So if anyone says end block is not the gold standard, do you want any of this to spill into the chest? And this is basically the tissue, all removed. You can see again my blue glove, how thin the capsular tissue is. You have calcifications here on the inside, all contained, none of this spill. Look, very soon it's going to spread to the side. This is much older technology, and you can see these hard calcifications that are present, and as you will see, I'm going to be able to snap them as well. So end block, totally disintegrated implant, and I'll tell you, there are a lot of patients, unfortunately, who are living with these ruptured implants, walking around, and it's not healthy to have this inside the body. That's why they say surveillance is key, and to remove them in a timely fashion. So I have a pair of gloves, sterile, on the left side, I removed the excess skin. I'm gonna go ahead and get this. So unblocked. So the left side was much easier, but again, you'll see, look at the capsular tissue. So I removed this tissue right here. This is bad inflamed. This was sitting right on top of the serratus anterior. So, and I'm gonna go ahead and dissect this out so you can see. You don't wanna leave this behind because you're gonna leave some of the bad tissue behind. It's all scar tissue, and you can see precisely why I remove it. I see some patients comment on leave behind the good precious volume. Well, I'll tell you, this is not good precious volume. This is all bad inflamed tissue. So in my practice, if it feels abnormal, looks abnormal, palpates abnormal, my sixth sense says abnormal, I remove it because I don't want to leave that silicone behind. And as you can see, look at this tissue. So what I'm going to do now is I'm going to go ahead and enter this area because I can see it's almost transparent. And it's a very slow and tedious dissection. This surgery is all about having that firm belief that en bloc needs to be done and all implants are ruptured till proven otherwise. I did a case last week and the patient had implants from 2010 and indeed she had ruptured implant. You have to always go in assuming that both are ruptured. Given her 1982 implants, clearly they were ruptured till proven otherwise. So as you can see how suffocated and different it looks here. And I'm going to go ahead and so overall, if you look at this one, and I can see this is probably the Dow Corning one. Let me see over here. So it says 235 cc's on it. 235. And there's and you can see like this is overall containing itself, if you can see, but still very much ruptured. We're going to look into that shortly, but as you'll see as I invert this open, all of this badness on the inside was removed with the capsular tissue and the inflamed tissue around. So as I cut this open, you can see this fatty tissue around is bad, angry, inflamed. If I flip this over, this is good tissue. This is bad tissue right here just by palpation and visualization. So that's why I removed it, incorporated it along with the capsule. And you can see, look at this brown consistency. Again, very old implant capsule and all that tissue was removed. So if you look at this and you look at this backside, none of this spilled out. And look at how this is at least maintaining its shape. Ruptured left breast implant. Look at this one, right one is completely disintegrated. So a lot of things that we can learn from this case. Number one, she's 74 at this stage given her presentation. This is not the time to be doing a lift. She's not going to get a drain. Twilight deep sedation. Cultures for Arabic, anaerobic, and fungal are going to be done now in between the implant and the capsule interface. The capsules will be sent to pathology. The right chest mass will be sent separately to pathology to make sure it's not anything abnormal like lymphoma or breast cancer, and certainly that silicone granuloma that I grossly visually see. And this is where the patient has the high definition pictures, videos of what we are doing right now, plus more importantly of the chest wall. This is extremely important, showing complete removal of the implant capsule with only good healthy viable tissue remaining behind. And she got the same surgery that every patient gets, where the whole total implant capsule and all inflamed tissue is removed. None of this spilled into the chest. Anything abnormal was incorporated with the capsule, and by palpation, if there was anything noted like a bad lymph node, that was to be removed as well. In her case, there was nothing abnormal. There was just this right chest mass, which is going to go separately. And then we'll see how she's going to do post-op minus these substances. Very important to always assume that the implants are ruptured to proven otherwise. The implants are not long lifetime devices. On average, 10 to 15 years if you listen to the FDA and the manufacturers. Anecdotally, 7 to 10 years before they start becoming a problem. And again, just as a reminder, if you look at the Mentor advertisement, the mentor recommendations, they want an MRI at year 3, and then every 2 years they're onward. The FDA will say get an ultrasound at year 5, and if there's any suspicion, get an MRI. And again, the bottom line is they need to be closely monitored, and around the 10-year mark, you really need to be seriously thinking about removal of that implant, because it will hurt. You do not want to wait and see a rupture and then kind of react proactively in that fashion. So there you have it. This is Dr. Khan, Executive Plastic Surgeon.